My name is Yezen. I am an internal medicine trainee at St. George's Hospital, and I'm also the founder at questmed.com. Today we'll be running through the epidemiology of stroke, risk factors, investigation, and also acute and chronic management of this very common disorder. So stroke is one of the most common causes of morbidity and mortality in the UK. 85% of strokes are ischemic, whereas 15% of strokes are hemorrhagic. So ischemic strokes are secondary to occlusion or stenosis of a cerebral artery, whereas hemorrhagic strokes are secondary to a rupture of a cerebral artery. The risk factors of stroke, as you can see, there are quite a lot. The thing that binds them together, I suppose, you can see age is common both, male sex as well. Things like hypertension, smoking, diabetes, all important to look at in any patient. The key aspect in terms of ischemic stroke is to look for atrial fibrillation. And the reason for that is if someone who has a stroke does have atrial fibrillation, you would consider anticoagulating them with either a direct oral anticoagulant or warfarin 2 weeks after the stroke. And if you look at hemorrhagic stroke, you can see that anticoagulation therapy is highlighted here. And the reason for that is if you have someone who has a hemorrhagic stroke who is on anticoagulation therapy, such as warfarin, you need to consider reversing that treatment. So through vitamin K, cryoprecipitate, and prothrombin complex or fresh frozen plasma. So there's a lot of options, but you need to consider reversing it early. So that's important to ask about to anyone who comes in with a hemorrhagic stroke. This is the first question, so please pause and have a read. The answer here is total anterior cerebral infarct. So you can see here that you have a patient with left-sided weakness, and they have got quite a lot of disability. So left arm and leg, left-sided homonymous hemianopia, left-sided neglect. So you can see here that it's important to know what side of the brain affects what side of the body. So you'll know that the corticospinal tract will cross. So if you have left-sided symptoms, you will have a right-sided lesion in the brain. And so that narrows it down to the right anterior and middle cerebral artery, or C, also right middle cerebral artery. So the other thing is you're considering whether or not it's a total or a partial cerebral infarct. In this case, you can see that there's quite a lot happening. So if you were to guess, you'd probably be right in saying that it's a total cerebral infarct. And the point here is that you have this classification called the Bamford classification, which is used quite often to distinguish between total and partial infarcts. And it's something that you should be aware of because we use it quite a lot in patients who come in with stroke. So we'll go through it in more detail. So here you have just a quick look at the total versus partial cerebral infarct. So you can see that the anterior circulation will most likely affect the lateral surface of the cortex, but also the medial surface of the cortex as well. Whereas the lacunar infarcts, which they tend to present with pure motor, pure sensory, would affect the deep structures, subcortical structures of the brain, and that is, as you can see, more likely to be a more focal process. Whereas posterior strokes, the highlighted structures here, you can see the cerebellum, you can see the brainstem, along with all the cranial nerves, and the occipital cortex, so you can also get a homonymous hemianopia as well. So this is just for you to review total, partial, and lacunar strokes, and as well the posterior circulation strokes as well. As you can see here, you get a lot of different things in posterior circulation strokes: cerebellar, the cranial nerve palsies, and eye movement disorders. So this can be quite difficult to diagnose sometimes, and can be associated with a later diagnosis, so it can be quite tricky in most cases. This is the second question, so please have a read, pause the screen. So this is a 72-year-old man who is unable to raise his right arm. He has a past medical history of hypertension, and blood pressure is slightly high but not very high, and there is a hyper-intense lesion in the left middle cerebral vascular territory. So the key here really is the CT. So the CT shows a hyper-intense lesion. So that is consistent with a hemorrhagic stroke. The CT head in a ischemic stroke most likely is going to be normal. In some cases, you may see a hypo-intense lesion, but the vast majority are most certainly normal. So the hyper-intense lesion here indicates that it's a bleed. So if we look at the choices, you would find that intravenous alteplase, aspirin, both inappropriate because they increase your risk of bleeding, so you wouldn't want to give that in someone who's got a bleed in their brain. And also clot retrieval is not appropriate because there's no clot, it's a bleed. And the last two, you would look at, first of all, intravenous labetalol. Intravenous labetalol, you would want to use that in patients who have very high blood pressure and stroke. In this particular scenario, the blood pressure isn't that high, probably be happy with that, so we wouldn't worry about it too much. So the most important thing is going to be supportive management, so making sure that you've done your A, B, C, D, E and the patient is stable, and also that you speak to the neurosurgical doctors about whether or not they would consider surgical intervention. And this is often based on certain factors such as the size of the lesion, the amount of disability they have, and also the Glasgow Coma score, but the indicators for your studies, it's not important at the undergraduate stage, so don't worry about it too much. Just know that you need to speak to the neurosurgical doctors if you have someone with a bleed and you need to get that assessed. So just to go back, so your ABCD is the most important. You do your CT head. If it's normal, you treat as ischemic. If it's within 4.5 hours, you may consider thrombolysis with alteplase. If there's a bleed, you would discuss with the neurosurgeons. Blood pressure control is very, very important as well because it reduces morbidity and mortality after you have a hemorrhagic stroke. And CT head, is it normal? Is it not within the window, the 4.5 hours? You would give 300 milligrams of aspirin for 2 weeks and then 75 milligrams of clopidogrel. And all patients will need physiotherapy, occupational therapy as well. Just a point is that if you have a large vessel thrombus on the CT, you could also consider mechanical thrombectomy, which is a treatment that has been shown to reduce morbidity and mortality in stroke by quite a lot. This is the third question, so please have a read. The answer here is clopidogrel 75 mg once daily and atorvastatin 80 mg once nightly. So basically the key point is in patients who have had an ischemic stroke, you would start them on a high dose of aspirin for 300 milligrams for 2 weeks, and then you would switch them to clopidogrel 75 mg once a day. And also you would consider starting treatment with atorvastatin, which is a lipid-lowering therapy. The other drugs are mainly incorrect because they combine aspirin and clopidogrel. You wouldn't normally give that in a stroke, except in certain very rare, much rarer circumstances. Certainly, you're not expected to know that at your level. You can give it in some people who have visible clots, who you want to help with the antiplatelet action. But for your purposes, you would give 300 milligrams of aspirin for the first 2 weeks, and then you would switch to clopidogrel. And the last one is incorrect because you would consider giving warfarin or a DOAC for someone who has atrial fibrillation, but we would see that the electrocardiogram ECG is normal. We could also consider doing a 24-hour tape or a 72-hour tape to look for atrial fibrillation. But from this question, the single best answer is going to be clopidogrel and atorvastatin. So chronic stroke management can be remembered by the mnemonic HALTSS. So hypertension, antiplatelets, anticoagulation, lipid-lowering therapy, smoking cessation is important, managing diabetes if it's present, and if someone has a carotid artery stenosis on the same side of the lesion, and if it's stenosed 70 to 90%, you would consider referral for a endarterectomy, which is trying to reduce the risk of clots being thrown from the carotid arteries into the brain and causing a transient ischemic attack or a stroke. Further investigations, again, we alluded to it earlier, 24-hour tape, we're asking the question, do they have atrial fibrillation? You would do an echocardiogram. Mainly you're looking for a cardiac thrombus, which can be a cause of stroke. And you're looking for modifiable risk factors, so you do HbA1c, cholesterol, blood pressure. Vasculitis screen is more important in young patients, so you may consider doing that. And that could include ANA, for example, ANCA, double-strand DNA, look at that. And carotid Dopplers, you would do that if you're looking for carotid stenosis, because that is a modifiable risk factor that can go on to treatment. So here's a summary. The key number you need to remember is 4.5 hours. You consider thrombolysis. Look always for atrial fibrillation because that can reduce the risk of stroke dramatically, especially in patients who haven't had a stroke, who have just had a transient ischemic attack. You need to make sure to screen for that. Ask about anticoagulation in every patient. As we said, it can affect lots of different factors in in acute and chronic treatment, and know your risk factors and how to investigate them. Thank you for listening. If you have any questions, please email me, yezen@questmed.com. Follow us on Instagram.